the introduction, 50% or more of the heart failure patients belong to the heart failure HFpEF, and prevalence is increasing because the aged population all over the world is increasing, and the HFpEF is one of the diseases of the aged people. Despite a lot of studies of the recent time, diagnosis still remains a challenge. HFpEF mimics need to be identified before we diagnose the case of the HFpEF. And management plan is being recommended by the American College of Cardiology, but there are many issues that has to be resolved. So I'll be pathophysiology of the heart failure with preserved ejection fraction, diagnostic approach, heart failure, preserved ejection fraction mimics, scoring for diagnosis, management plan, and the take-home message. This is the simplified form of the pathophysiology of the heart failure with preserved ejection fraction. You see the obesity or metabolic syndrome. I can see here. Yeah. Obesity and metabolic syndrome, the arterial hypertension, obstructive sleep apnea syndrome, and the COPD, diabetes mellitus, physical and inactivity, chronic kidney disease, and iron deficiency. All these lead to the systemic inflammation. And these systemic inflammation, which are recognized by different parameters, then this lead to the microvascular inflammation, endothelial dysfunction, and microvascular ischemia. These are the gross pathophysiological mechanism, and this leads to the LV hypertrophy and myocardial fibrosis. This leads to the diastolic dysfunction, and ultimately we get the features of the heart failure with preserved ejection fraction. So no single test is available to establish the diagnosis. Accurate diagnosis may be challenging because of there are multiple HFpEF mimics, a newly identified subset of patients with HFpEF, and normal plasma natriuretic peptide concentration in many cases of the HFpEF, though the natriuretic peptides as the marker of the heart failure, but in the HFpEF, in many cases it is normal. HFpEF is defined as a clinical diagnosis, mostly by the clinical diagnosis with the left ventricular ejection fraction more than 50%. It is not synonymous with the left ventricular diastolic function. There may be diastolic dysfunction, but there not be the HFpEF. And the HFpEF mimics the cardiac and non-cardiac. I will discuss in the later slide in details. So some individuals who present with the symptoms of dyspnea and or edema may not have the heart failure. So non-cardiovascular entities that mimic the heart failure are the kidney failure or nephrotic syndrome, the liver failure or cirrhosis, anemia, severe obesity and the peripheral edema, lung disease with or without COPD, and the primary pulmonary hypertension, and the chronic respiratory failure, hypoventilation. These are the features, these are the conditions where there may be dyspnea as well as there may be edema, but they not be the heart failure with preserved ejection fraction. They are the mimics of the heart failure with preserved ejection fraction. These are the non-cardiovascular entities, and there is some cardiovascular entities, particularly the cardiomyopathies, structural, special or unusual cardiomyopathies, infiltrative or restrictive cardiomyopathy, hypertrophic cardiomyopathy, valvular heart disease, pericardial disease. These are all the non-cardiac causes that are not the HFpEF, but they are the HFpEF mimics. Mind it, the cardiac amyloidosis once is considered as the HFpEF, but now it is a separate entity. It is the HFpEF mimic. So exclusion of the cardiac and non-cardiac mimics is necessary before diagnosing the HFpEF. A good clinical history and the physical examination along with an echocardiogram is most cases is suffice to diagnose. The gold standard to confirm or refute a diagnosis of HFpEF is based on demonstration of the elevated LV feeling, raised LV feeling pressure. Cardiac catheter is the confirmatory test, and other pathologies giving us to similar symptoms should be excluded. So these are the scoring system by the American College of Cardiology. There are the 9 scoring points. The H2 the heavy, that is the BMI more than 30 kg per square meter, 2, the more than 2 antihypertensive drug patient, the 1, atrial fibrillation 3, pulmonary hypertension 1, E, elderly more than 60 years 1, F, filling pressure, E by E ratio more than 9 is 1. These are the very simplified scoring system for diagnosis the HAPEP developed by the SEC in I see 2022. And this is the another ESC developed a scoring system. They said that the HFA, Heart Failure Association, PEF means P means pre-test assessment, symptoms and signs of the heart failure, comorbidities or risk factors, and standard echocardiography. These are the 3 points for the pre-test assessment of the HFpEF. Then the echo and natriuretic peptide assessment, E, the comprehensive echocardiography at the natriuretic peptide level. Then the functional testing of the, in case of the uncertainty, which is done in some special cases. And finally, the etiology, if we like to know the etiology, there is some test. If I elaborate this, elaborate these points, the scoring of the echo parameters and natriuretic peptides. These are the functional, morphological, and biomarkers. In functional, septal E prime less than 7, lateral E prime less than 10, average E by E prime more than 15, TR velocity more than 2.8. These are the 4 parameters having 2 points, only 2 points, either of 4. And the morphological, left ventricular enlarged more than 34, and left ventricular muscle index is more, mass index is more than 149 in males and 122 in the female. These are also 2 points in the measure point. And the biometric is the sinus rhythm, the NT-proBNP more than 220, or the BNP is more than 80. These are the 2 points. These are the 6 points. And these are the below, in the black letters, these are the 1 point, minor point. So each major parameter is 2 points and each minor parameter is 1 point. And if the points is 5 or more, then it is the likely that it is the HFpEF. Though it appears to be very clumsy, but it is not so. If you go in details, go through the parameters. These are the blue line is the major parameters, 2 points, and the black is the minor parameters, 1 point. But in each group, either you take 2 or 1, each group. And you know, this is the E by E ratio, E prime. E prime is very important for the diagnosis of the diastolic dysfunction. As I say, the E prime is the 6.7, E by E prime is 13.4. So there is the diastolic dysfunction is one of the parameters for the diagnosis of the HFpEF. So these are the 2 patients of the similar, say 61-year-old woman here. The man individual B is man, stage 4 chronic kidney disease, atrial fibrillation, both are common. But hypertension on 3 medication in individual A, and the carpal tunnel syndrome or the lumbar spinal syndrome. You know, one of the features of the amyloidosis is the carpal tunnel syndrome, BMI 31 kg and BMI 24 kg. The individuals with the same features in the first 3 points, but their points is the HFpEF score is 9 and the H2FF score is 5. So these patients are of the HFpEF, but though that patient is not, does not belong to the HFpEF. This is the one of the algorithm. The patient presented the symptoms of edema with the ejection fraction more than 50, apply the universal definition of the heart failure. Whether the patient is in the heart failure in the clinical diagnosis by the universal definition. Then consider the non-cardiac mimics, that is kidney disease, liver disease, chronic obstructive disease. If no, then go to the other cardiac mimics. Does the patient presentation in the infiltrative cardiomyopathy, the hypertrophic cardiomyopathy, pericardial disease, valvular heart disease, high output heart failure. These also no. Then it is the heart failure with preserved ejection fraction. You have to exclude by exclusion you come to the diagnosis. Then there is a heart failure preserved ejection fraction with associated comorbidities. It may be hypertension, diabetes, atrial fibrillation, obesity, coronary artery disease, renal dysfunction. These are all the comorbidities of the HFpEF. These are the not causes of the heart failure, HFpEF. So management is the relief of the symptoms. Loop diuretics are recommended. Disease modifying therapy, only the SGLT2 inhibitors are recommended. Class 1 indications by the American College of Cardiology, as well as the ARNI and the angiotensin receptor blockers, particularly the candesartan. And management of the comorbidities and non-pharmacological is no less important, particularly the exercise and the weight loss. So these are the many trials, and these are the same things: medical management, non-pharmacological management, and the management of the comorbidities. Our approach should identify, risk stratify, and manage the comorbidities, counseling regarding the exercise and the weight loss, and then the pharmacological management. Remember that the pharmacological management is yet to be ideal. So we have to depend mostly on the exercise training and the weight loss. I can skip it. These are the drugs which we can use: the empagliflozin, dapagliflozin, aldosterone antagonist, the spironolactone, ARNI, and the ARB, particularly the candesartan. A number of the trials failed to show benefit of the different therapeutic agents in the HFpEF negative trials, and the trials of perindopril, irbesartan, beta blockers, nitrates, digoxin, ivabradine, sildenafil. These are all the trial failure. Role of beta blockers is very important to consider. Mind it, the beta blockers are useful in the presence of comorbidities like ischemic heart disease and AF. But as a per se, beta blockers are not indicated in the heart failure with preserved ejection fraction. Rather, they may be proved to be harmful, because the beta blocker withdrawal in some cases in some trials show that there is a beneficial effects of the withdrawal of the beta blockers, because there is a chronic incompetence associated with the HFpEF. So this is the recommendation for the American College of Cardiology in 2023. First of treatment is the SGLT2 inhibitors, and then for individual with fluid retention, loop diuretic. For women in ejection fraction, in any ejection fraction, and the man with the ejection fraction around 55 to 60, those with fluid retention, add MRA, spironolactone. For women in all ejection fractions, and the man with the ejection fraction around 55, add the ARNI. And if there is ARNI is incompatible, then add the ARB. So in women, there is someone is talking about the heart failure in women. In women, the SGLT2 inhibitors, man and woman the same, but in the ARNI and in cases of the MRA, it is more effective in women heart failure HFpEF than the man. And non-pharmacological is the exercise and the management of the obesity, particularly you see GLP-1 agonist for the management of the obesity in the overweight patient in the heart failure is indicated. There is a large trial recently that the GLP-1 is a very good drug for the weight management in cases, and they improve the symptoms of the HFpEF. And pharmacology I have also. So, ladies and gentlemen, having said so, the HFpEF is more than 50% of the heart failure patients. But sometimes we say the heart failure with reduced ejection. We forget about the heart failure with the preserved ejection fraction. Pathophysiology and clinical presentation are complex and quite different from the heart failure with reduced ejection fraction. And there is a dilemma in the making diagnosis. Still now, there are conditions, mimics, both cardiac and non-cardiac, that need to be excluded to reach the diagnosis. Association of number of comorbidities needs proper evaluation, and scoring system is a very good practical tool for diagnosing the HFpEF. Management includes both pharmacological and non-pharmacological, and non-pharmacological is important in the exercise program and the weight management. No clear evidence that the pharmacologic therapy, diet, or other therapies reduce the risk of mortality in patients with the HFpEF, though there is some drugs in cases of the heart failure to reduce ejection fraction, where there is a benefit of the mortality, but yet to be proved in cases of the HFpEF. I think that is my end of my lecture. Thank you very much for the passion here.